So this is the case history you have given, isn't it?
Yes, sir.
40-year-old lady, height 5'2". Is my voice clear for all of you?
Yes, sir.
Okay.
Yes, sir.
Right. So the first question is, what is the BMI of this patient?
So the BMI is 52.48, sir.
52.4. How did you calculate that?
Sir, I converted the 5 feet 2 inches into the centimeter form, sir.
Right in
I converted the height into the unit of centimeters.
meter, not
Uh,
centimeter.
meter, yeah, meters. And I used the formula of weight in kg divided by square of height in meters, sir.
Height in meters. So you got a. So this patient is a normal patient or obese patient? The
Sir,
BMI is
since
52.5.
the patient falls under the category of super obese, sir.
Super obese patient. So what is the
Yes.
definition of obesity? How do you define obesity?
The presence of excess weight for the patient's age, gender, height, and it's estimated on the calculation of few formulas.
An abnormal deposition of fat. Okay, the obesity is abnormal deposition of fat compared to the height and weight. So how will you classify obesity based on BMI? What are the classes of obesity?
With a BMI of more than 30 kg per meter square, they're considered as obese. In obese, we have three categories: grade 1, class 1, class 2, and class 3. If the BMI falls under 30 to 34.9 kg per meter
You can
square, which is
roughly say
class.
35. Even if you say 35, it is not a mistake. Okay.
Yes, sir. Then 35 to 40, the patient is falls under category of class 2.
Two.
And if the class 3, the BMI is more than 40, which we call it as a morbid obese. And if the BMI is more than or equal to 50 kg per meter square, we call it as super obese. If the BMI is more than or equal to 60 kg per meter square, we call as super obese.
Super obese. Okay. So what are the patterns of obesity?
We have two patterns, sir, android and gynecoid pattern. Android or central, and gynecoid or peripheral type of.
So which is common in which sex?
Android type of obesity is common in the male. We have a pattern of adipose tissue over the upper truncal body. In gynecoid type, which is common in female, here the fat deposition is most common in the hip, thighs, and buttock areas.
Very good. What is the pathophysiology of obesity? Why patients become obese?
Physiology of obesity. Visceral adipose tissue deposition.
Why?
And,
how does it happen? Pathophysiology means you must explain the mechanism how this adipose tissue gets deposited or gets increased. What are the mechanisms? Can they be classified into genetic factors, environmental factors, social and psychosocial factors like that? So you have to classify them. But the main reason is more intake, less expenditure. Caloric intake is more, but the calorie expenditure is less. So whatever excess energy or excess intake is there, it is converted into triglycerides and stored in the adipocytes.
yes.
Normally, the number of adipocytes are fixed according to the genetic nature of the person. But beyond the BMI of 50, these adipocytes not only increase in size, but also they multiply and become more in number, and that causes the obesity in the patient. Okay, that is the pathophysiology. Why central obesity carries more risk compared to peripheral obesity? Gynecoid obesity.
It is metabolically high active, and more oxygen consumption is needed.
Is it because of that more oxygen will be needed in all obese patients? Whenever they increase their body weight, their need for oxygen as well as the blood supply is more, because the overall surface area also increases, isn't it? So the cardiac index increases. The requirement of blood to be pumped to the tissues increases. But the reason why central obesity, what happens in central obesity? Which organ or which content in the abdomen becomes more fat laden?
Liver,
Have you
pancreas.
ever seen an obese patient being operated laparotomy?
Yes, sir.
Yes, sir.
Which part of
Liver,
the intra-abdominal content
Acute.
will become more thick and more voluminous?
Subcutaneous.
The omentum.
momentum,
Okay, the
Omentum.
omental deposit, and omentum produces what enzyme?
lipoprotein lipase.
Lipoprotein lipase. Excellent. That is the enzyme which is very active, and when the central obesity causes all the metabolic changes because of the excess activity of the lipoprotein lipase enzyme. Okay, so obese patients also become insulin resistant and they develop diabetes mellitus. What is the reason for that?
Uh, in, uh, Due to the high activity of pro-inflammatory state,
I,
due to the increase in the pro-inflammatory state,
ah,
we usually end up in the insulin
what
resistance.
happens to insulin secretion first of all? Is
It's
it increased or decreased?
Increase, increase,
It
but
is
the response.
decreased.
Okay.
There is a fat
Decreased.
deposition in the pancreas also. Okay, so that
Yes.
causes a particular decrease in insulin. Second thing is, whatever insulin is produced does not have the sensitivity to act on the cells. So insulin sensitization is also reduced. And the inflammatory cytokines are also produced. All these factors lead to insulin resistance, and patients invariably become. And this is the reason why if you treat the obesity in these people, the diabetic state will get totally reversed. Unlike the normal diabetic patients who are lifelong diabetics, can only be controlled. The insulin, the diabetes that is occurring in obesity is reversible. It can be completely eradicated if your obesity problem is taken care of. Okay, that is one of the advantages of doing bariatric surgery or the weight reduction surgery, which helps in resistant diabetes in obese patients. So, what are the genetic factors involved in the causation of obesity? Which any particular production of any particular hormone genetically affected? Have you heard of melanocortin?
Yes, sir.
So melanocortin is responsible for that. And what are all the various changes that happen in this various system because of obesity? This is another common question they will ask you in the exam. Let's
Yes.
start system wise.
Starting with the respiratory system, there will be a fat accumulation over the chest and abdomen. So there will be decreased compliance in the chest wall and lung, and there will be increased elastic resistance due to the compliance of chest wall, and which is also reduced in supine position. So these patients will have a rapid and shallow breathing, and they will have increased work of breathing, and respiratory muscle efficiency is also below normal, and fall in the pulmonary complaints because these patients will have a reduced FRC and reduced expiratory reserve volume. And the relationship between the FRC and the closing capacity is also affected. So the small airways tends to close in these patients. So they will have a VQ mismatch, shunting, arterial hypoxemia state. And obese patients have an increased oxygen consumption and carbon dioxide production even at rest time. This is due to the increased metabolic activity of the adipose tissues and increased workload on the supportive tissues also. So these demands are always met by increasing cardiac output and alveolar ventilation. normocapnia is maintained by increasing the minute volume. Then the chronic hypoxemia state will lead to polycythemia, pulmonary hypertension, and pulmonary state. Other than that, these patients will have obstructive sleep apnea, which can be either periodic, partial, or complete obstruction of the upper airway. And physiological changes to OSA will also be there, like hypoxemia, hypercapnia, pulmonary hypertension, systemic vasoconstriction, hypertension, secondary polycythemia. So the risk of ischemic heart disease, cerebrovascular disease will be there. Further, these patients either will be on a CPAP or we need to start them on a CPAP based on the stop band questionnaire and everything.
Okay.
And
We
this
don't
can
have to elaborate on this treatment part of it. The various changes in the system. You can just mention the changes and stop there. You need not go on to describing about the treatment modality like CPAP and all that. Okay.
Yeah.
Overall, the involvement of respiratory system, does it produce an obstructive airway disease or a restrictive airway disease?
it produces a mixed pattern, but most common is a restrictive type of pattern.
Is these patients more prone for bronchial asthma or less prone for bronchial asthma? With these patients?
They are more prone for bronchial asthma.
So in that case, what will be the type of disease they will have?
Mixed pattern can be seen.
Yes, they will have a mixed type. So you must always ask a history of obesity patients. You should also ask history of asthma, so that they will have more problem because of both restrictive and obstructive nature of the disease. Okay, right. What about cardiovascular system changes? Oh, your audio is giving trouble. Your voice is breaking. And somebody else who is good, they can take over. Their voice is breaking.
Yes, sir. Cardiovascular system, systemic hypertension, risk of coronary artery disease, myocardial ischemia.
Very good.
Due to the
biventricular failure, sir.
Okay. When will they
Due
have
to the-
biventricular failure?
Due to OSA, patients can go into pulmonary hypertension and
Very good. So if the patient has systemic hypertension and OSA, they will develop pulmonary hypertension, and in that situation, in advanced cases, they will develop biventricular failure. If they have only systemic hypertension, they will have only LVF. Okay?
LV hypertension.
Right, go ahead. What are the changes in the gastrointestinal system?
In GIT, these patients will have a increase in gastric volumes, like more than 25 ml, with the low pH, like acidity, will be there. They also have increase in the intragastric pressures, and hiatal hernia presentations can also be there. Hepatic functions can also be altered due to the fatty deposition. So these patients can have a NASH presentation with the raised ALT levels. Then cholelithiasis can also be there.
Okay, what about GERD?
GERD, complaints of GERD will also be there.
First and foremost, you must mention that GERD is very common
they
because
have
of the angulation.
Delayed gastric emptying and reverse.
Okay.
Yes, sir.
What
Then
about
coming to renal and endocrine changes, these patients will have a increase in GFR as the renal blood flow is high, and impaired glucose tolerance will be there, which can show the type 2 diabetes mellitus prevalence. And They also these patients will also fall into the category of metabolic syndrome, which comprises of central obesity with a waist circumference in 1 or 2 centimeters in male, more than 88 centimeters in female. Other than that, triglyceride value of more than 150 milligram per deciliter, HDL value which is less than 40 milligram per deciliter in male and less than 35 milligram per deciliter in females. Other than that, these hypertension or hypertension presentation, or they could have been on antihypertensive drugs, and increase in the fasting blood sugar values. Other than that, these patients will also be in a pro-inflammatory states and pro-thrombotic states. So they are highly prone for DVT and pulmonary embolism in the post-op.
What about
Polycythemia,
musculoskeletal?
musculoskeletal.
But they're more prone for
Osteoarthritis.
OA and other things because of the weight.
Yes, sir. These patients will have a complaints of arthritis also. Further,
Especially weight-bearing
psychos
joints will be affected very much. Okay.
yes, sir. Further,
And what about the
psychosocially, these patients will have a low self-esteem, poor social stigma, and low in the confidence level.
so what is OSA? What is the definition of OSA?
Repetitive sleep apnea.
How do you define that? What is the definition of OSA? When will you call a patient is having OSA?
Partial or witnessed partial or complete obstruction of airway.
It's not the correct definition. Anyone else who can say the correct definition of OSA?
Cessation of airflow
Can the
for
patient-
more than 10
Ah.
seconds. Episodic
Ah,
cessation of airflow.
episodic repeated
Cessation
of respiration for more than 10 seconds. Okay, that is the correct definition of OSA. Now, what are the symptoms of OSA? The patient suffers from OSA. Many patients with obesity, they don't know that they are suffering from OSA when they come to you for the first time. So how will you, in all obese patients, you must ask our symptoms and find out whether they are suffering from OSA. They have not already been diagnosed with. So what are all the common symptoms? When you probe and ask by questioning, then you will elicit.
We can categorize them in a stop bank questionnaires like snoring, tiredness, observed cessation of breathing or choking or gasping during sleep can be asked. Other than that, excessive daytime sleepiness, impaired concentration, memory problems, and morning headaches or usually will be there. Then we need to check whether the patient fits into the stop bank questionnaire also.
So how is sleep apnea classified? I'm not asking about obstructive. It is just sleep apnea. You see the question properly. It is how is sleep apnea classified? Can be classified into two groups, central and peripheral. When it is, what are the conditions which produce central sleep apnea? What are the conditions which produce peripheral sleep apnea?
The Pickwickian syndrome is usually
Pickwickian syndrome is a part of severe obese patients, extreme states of obesity, which produce severe not only restrictive but obstructive airway disease, causing hypercapnia.
So narcotic induced central sleep apnea.
Head injury or narcotic induced will be the central pattern of sleep apnea, where patients reduced respiratory, total absence of respiratory attempt will be there. Whereas here it is a reduced attempt. There will be no total cessation or absence of effort. There will be effort in peripheral sleep apnea. Patient will try to breathe, but the airway gets blocked because of the falling of the tongue or the excessive fat around the neck area, collapse of the pharynges. So that causes the obstruction in peripheral sleep apnea. So patients, if you see the abdomen, there will be some movement of the diaphragm. Whereas in the central sleep apnea, there is no effort at all. The diaphragm gets totally functionless for a few seconds and then it restarts. So what investigation is done to confirm OSA and how do you interpret the results?
Gold standard investigation is polysomnography, sir.
Polysomnography. How is it done? Any idea?
It's a overnight sleep study which involves EEG, ECG, EMG, and EOG patterns, sir. Uh,
So what are the things that are measured during this observation of overnight polysomnography?
um,
What is apnea-hypopnea index?
which is summation of apnea and hypoapnea episodes divided by the total sleep time, which comes as apnea hypopnea index. Here we grade it as mild, moderate, and severe. If the value is in between 5 to 15 events per hour, which is mild, 15 to 30 events per hour, which is moderate, and more than 30 events per hour, we call it as a severe.
Severe.
Event.
What is respiratory distress index?
The sum of apnea, hypopnea, and arousal events.
So the combination of all the three is called. So this is calculated by adding the apnea-hypopnea index to arousal index. How many times the patient woke up? If both are it's called AA. Arousal index is AA. Apnea-hypopnea index is AHI. AHI plus AA is equal to respiratory distress index. Okay, that indicates the severity of the disease. What is metabolic syndrome and what are the other names for that metabolic syndrome?
Syndrome X.
Syndrome X, group one name. Anything else? Only one name? Okay, I will tell you that later. What about the treatment for obesity? There are actually three other names for that metabolic syndrome. One is syndrome X. There are two other names. I'll show you in the next slide what I am. So what is the treatment for obesity? How do you treat if a patient with obese wants to get treated? How do you treat them?
It can be non-pharmacological or pharmacological methods. Coming to non-pharmacological, we can go for a self-monitoring, nutrition changes, a low-calorie diet with a high protein intake, exercise, and behavioral therapies which can boost up their confidence. Other than that, pharmacological, these patients can be started on phentermine or topiramate or leucoserin or liraglutide or Listat tablets. Certain plant extract and herbs are also being used.
What about surgical?
So yes, surgical, like bariatric surgery, if the patient is falling into category of class 3 obese, or the patient is with a BMI of less than 35, plus the comorbid is not controlled under the medical therapy. They can go either for a malabsorptive or restrictive type of surgery, or combined approach, which is Roux-en-Y gastric bypass, can also be seen.
Okay. So how to evaluate this particular patient, this case scenario case given here, 40 years lady with a BMI 52.5, posted for incisional hernia repair and abdominoplasty. What are all the important history you want to take from this patient?
I'll ask for the main presenting complaints, sir. How long she's having this incision hernia? I mean, the size of hernia. Like the size of hernia, anything which is precipitating increase in the swelling or everything. Other than that, I'll ask for the comorbids, like she's on any medications, like asthmatic, diabetic, or hypertensive, or any history of CAD, we can ask her. Other than that, I'll falling into category of OSA and whether she has been started on a CPAP therapy or not. And her other than that, we can go for a general examination for the vitals.
No, I'm
Vitals
asking
being
only
checked.
about history taking.
Only
Here,
the-
I'm not asking about the general examination. What is the most important thing you are missing in this history taking?
Uh, uh, mm,
Huh?
why the hernia? I mean, what surgery was done earlier and
Previous surgical
what?
repair. That is very, because this is an incisional hernia, means she has had a surgery done earlier, and that incision has now given
Yes,
way and she has developed a hernia. So when was the surgery? What was the surgery? What was her condition at the time of surgery? What type of anesthesia was given at the time of surgery? Was there any intra or post-op complications? So you should
complications.
not forget that. That's a very, very important history. Probably she would have had a cesarean when she was
Yes,
25. At the time, she would not have had any morbidity, comorbidity like obesity or diabetes or hypertension. After that, she would
yes,
have started putting on weight and she would have had that. So for a cesarean, she could have only received a spinal subarachnoid block. But later on, if
yes,
she has had a cholecystectomy or if she had had a hysterectomy at the age of 38 or 39, and at that time also she was obese, then you could ask what was the problem, what the anesthesia was given to you, was it GA or regional? Did they tell you anything about difficult airway? All those questions you can ask and find about that. So if any case is given as incisional hernia, do not forget to ask about the previous surgery which led to this incisional hernia and the
yes,
intra-op and post-op problems or anything, if anything has occurred during that time. That is a very, very important history to guide you to take adequate measures to prevent the same complications recurring again. Okay? Sometimes the
yes,
patient might have been put on ventilator post-operatively. All those history is very, very important. Okay, so don't
yes.
forget that. If it is a simple straightforward inguinal hernia or a femoral hernia occurring for the first time, you don't have to ask all these questions, right? Okay. So what investigations are needed in this patient?
I'll ask for the basic investigation. See,
Routine
uh,
basic pre-surgical
yes,
investigations can be
CBC,
asked.
viral markers, coagulation profile, LFT levels, and ECG, chest X-ray, and echo will be asking.
Make sure that any diabetic state is there or not, hypertension, whether they are all controlled, all that. So what are the pre-op optimization, the instructions you have to give this patient?
We need to explain about the NPO status, like 6 hours for the solids and 2 hours for clear liquids and hydrogen. I'll also give antacid prophylaxis as an like to prevent any aspiration and everything. Further, I'll also give an antibiotic prophylaxis, an anti-emetic prophylaxis also, and since she is falling to morbid obese, risk of DVT is high. So I'll go for an anticoagulant, one single shot, like on the evening of surgery. It will be like 12 hours before surgery.
If supposing patient gives history of OSA and already be on treatment.
I will recommend her to bring the machine along with her and like continue the CPAP or BiPAP. She's I will recommend to bring it on the post-op also.
That's a very important thing. Let's not forget. Okay. Describe the intraoperative management if you are planning to give GA for this patient.
Starting with wheeling inside the theater, we require additional help, like pulling the cot inside and everything. Specially designed like wide trolleys and specially designed tables which can hold more than like 400 kgs and with a greater width and side accessories, strappings to hold her and need to be there. Next is the monitors. The BP cuffs should we make sure that it is encircled to 75% in the upper arm. And about the IV axis also, it might be a bit difficult and challenging in these patients. Then the positioning for the pre-oxygenation, I'll recommend a little like like head and elevation or a 30-degree elevation of the head, so that the tragus and the sternal notch falls in line. And this ramped position is also good for the patient and also for the for us to increase the laryngoscopic view. Other than that, I'll also go for apneic oxygenation while trying for and airway closure is more pronounced when these patients are on, so measures need to be taken.
So you plan for IV induction and intubation with the conventional way with laryngoscopy, is it?
Yes, sir.
So how do you know that it is going to be easy? The most important thing
I'll
that you
ask for a
must say
different
Position of
airway
the
path.
patient.
Different
Ah,
airway path to
when they ask
uh,
about intraoperative management of GA in obese patients, your first answer should be a proper airway assessment to rule out anticipated difficult airway. That is the first and foremost answer you must say before starting about the tables, the fixation, the strapping, IV access, everything. You must make a thorough preoperative evaluation of the airway to make sure whether it is going to be a difficult airway or a non-difficult airway. There are many obese patients where they have adequate mouth opening, good neck extension, adequate jaw length, where you can, it will be like a Malamati grade 1, you can easily intubate. In that case, you can go for a straightaway conventional IV induction, relaxation and intubation. On the contrary, if you have any doubts about it and if you anticipate difficulty with a very short mandible, thick pad of fat around the neck, very limited neck extension,
short mouth and
then you must decide whether you are going to do an awake fiber optic intubation or do an attempted conventional induction intubation. Okay, these are the two things that you have to decide before you talk about the intraoperative management. The second most important thing is pre-oxygenation. If you are planning to do GA with conventional airway control, then pre-oxygenation becomes very, very important. So it should be at least for 3 to 5 minutes in a regular way, unless it is an emergency. And you must, as you say, if you anticipate any difficulty, you must make sure that you have all the equipments and gadgets ready for providing apneic oxygenation to prolong the safe apnea time, which are all the terms that you should use in the examination. Safe apnea time, prolong the safe apnea time. Okay, so that is all the thing that you have to say. And what are the advantages and disadvantages of regional anesthesia in these obese patients? Supposing it is only a lower abdominal incisional hernia below the umbilicus and a pendulous abdomen where they want to resect that excess fat and do an abdominoplasty, it can be managed under regional also. So what are the advantages and disadvantages of regional in obese patients?
So there can be and also there can be reduced PO invaders and only few drugs will usage will be there in regional and good post-op pain control can be expected. So the post-op outcome will be better. The one thing is positioning them for the regional and obscured anatomical landmarks or UST guidance and the equipments what we use like a long needles for them, longer needles for them. These are few things.
So it may be a technically challenging task for these patients, especially morbid obesity. You may not be able to find the spinous process palpating them is very difficult. So that is the most important drawback. And these patients for a prolonged surgery may not be able to lie comfortably in a conscious state in the supine position. Okay. So many of them, if they have OSA, they may be sleeping in the lateral position to avoid the obstruction. So that may also be for one of the disadvantages of regional. What are the monitoring challenges in these obese patients? You already mentioned about the BP cuff. You require extra large BP cuff. If that is not available, what can you do? If you have only the regular
We can
size,
tie on the forearms or the legs for the measurement, sir.
yeah, so you will get the same reading even if you tie it in the forearm, or sometimes very obese patients, the prolonged surgery with a lot of fluid shifts anticipated, it's better to
So we
go
can
for
go
a
for
arterial
arterial lines.
monitoring also. Okay. What about the ECG electrodes? What is the challenge with the ECG monitoring? What will be the nature of the complexes that you get? Will it be a normal like a thin patient, or will it be low voltage complexes?
Low voltage.
Low voltage complexes can be expected.
So that will be another challenge. And what about the temperature monitoring in these patients? Are they likely to become hypothermic?
Obese patients have a high metabolic rate, sir. So the
They will maintain their temperature, isn't it?
like
Under anesthesia,
is
what
it
will happen? Will they lose heat or they gain heat?
they will lose heat, sir. The core
Ah,
temperature will fall.
fall.
So we
We
can
must
use
take adequate precautions to maintain their body temperature. Okay, so proper airway, I mean body covering and temperature monitoring should be done. And how is the drug dosing done in these patients? How do you calculate the drug?
the lipophilic drugs can be given according to their ideal body weight, and like hydrophilic drugs can be given according to the total body weight. Like when coming for scoline, we can go for a total body weight. Like
So there are three body weights that you have to remember. One is total body weight. Second is the lean body weight or lean body mass. Third is the ideal body weight.
ideal body.
The drugs have to be calculated depending upon their lipid solubility or hydrophilic nature, based on total body weight, ideal body weight, or lean body. How about the fluids? How will you replace fluid loss in these obese patients? Is it on total body weight or
We can go by ideal body weight.
ideal body weight? So not on total body weight. What are the precautions you have to follow during recovery from GA in these obese patients? What is the after completion of surgery? Will you extubate the patient
Yes,
the
ideally
regular
we
way?
need to do a wide awake extubation in a sitting position or semi-recumbent position. Two anesthetists presence can with people can be used for extubation. We need to observe them at least 5 to 15 minutes after extubation, and we need to watch for hypoventilation.
And if they are using CPAP or BiPAP machine, that can be immediately applied and taken to help them. What are the post-op care and pain management in these patients?
We need to be liberal on the analgesics, like especially the regionals. Oxygen supplementation, we can go for head and elevation, continuous vitals monitoring, especially the saturations, everything. We can go for early ambulation. Terminal binders for support can be used.
PVT prophylaxis, opioid
PVT
sparing
prophylaxis.
analgesia. These are the two terms that you should use operatively: early ambulation and DVT prophylaxis, and respiratory exercises to prevent basal atelectasis. Three, opioid sparing analgesic techniques. So that don't, especially if they have OSA, avoid narcotics as much as possible. Okay, go for any blocks or regional techniques, and drugs like NSAIDs, magnesium, lignocaine, vitamin small dose infusion. All these things are called opioid sparing techniques of analgesia. Okay? So we'll stop with that, and